ተናደርክ? ይሰማል? ጌትነት ይሰማል? ማለት ገሊላ ሄሎ ይሰማል?
ይሰማል ዶክተር።
እሺ Okay, let's get started. You hear me? Do you hear me? Someone?
Hello.
نجمر بقى. So last time, because we have to finish on time, if you remember, I discussed the 4 basic moments that needs to be seriously considered before we decide on treating with antimicrobial agents. So as I have already said, I'm going to use these phrases interchangeably: antibiotics, antimicrobial therapy, okay? And these are the 2 words which I'm phrases which I'm going to use interchangeably. The first step is, in our decision-making process, what we need to consider is, does my patient have an infection that requires antibiotics? And as I have said, as our difficulty, particularly in critical ill patients, is to differentiate between infection and inflammation, because the presentation and most of the lab features are similar, so very difficult. Hence, in most instances, we embark on treating with antibiotics. In which case, before we start treatment, what we have to make sure is collecting the appropriate samples for microbiological studies. And then after starting therapy, we have to evaluate our patient daily. And if the microbiology results arrive, then we have to scale down, de-escalate the antimicrobial regimen, because what I always say is, whenever you have a critical ill patient, you have to start with broad spectrum agents, try to cover, empirically the possible organisms. And then once you have the microbiology result, the culture, you have to de-escalate. Now we have come to realize that, 5 to 7 days of antibiotics treatment would suffice. So no need to continue beyond that, except for some infections like bloodstream infection, infective endocarditis, in osteomyelitis, chronic prostatitis, and the like. Except for these few conditions, there is no need to continue beyond 7 days. The other thing I discussed is, in order to rationally use or appropriately use antimicrobial agents available in Ethiopia, we have to learn about the formulary, okay? The drugs that are available in our setting. So I have said that we have almost all beta-lactam, which are the most important group of antimicrobial agents. We have all of them, nearly all of them. So we don't need, to my mind, we don't need any more. We have, most of the antibiotics are available. Okay, so there is a little need for more, except that now, because the carbapenem resistant Enterobacteriaceae is spreading, we need agents like polymyxin, colistin, tigacycline, and the newer generation cephalosporins. So we need them in our armamentarium. And today, what I'm going to discuss is, do you hear me? Hello?
It's
a passive way of learning, so very difficult to follow if you are listening or not. That's very difficult. So this is the downside of virtual learning. So very difficult to follow your audience. So the antimicrobial agent, based on their action on the different bacteria, now we have come to realize that the most important group of antimicrobial agents are the beta-lactam. Why? Because the beta-lactams are the effective, the drug of choice for gram-positive aerobic, gram-positive anaerobic, okay, cocci, and gram-negative bacilli, except for intracellularly replicating pathogens, because these are ones do not have cell wall, like the mycoplasma, chlamydia. Beta-lactams inhibit cell wall synthesis. Bacteria which do not have cell wall are intrinsically resistant. So that's why we say the most important group from all agents are the beta-lactams. That's why we can't afford when resistance develops. When widespread resistance develops to beta-lactams, we call it extended spectrum beta-lactam is producing bacteria. These are many gram negatives. What that implies is bad prognosis. So the most important group effective against most bacteria, I would say all except for intracellularly replicating pathogens, are the drug of choice are beta-lactams. Okay? Aerobic as well as anaerobic. That's why we can't afford. So that's very difficult. When we encounter patients are allergic to this class of drugs or when resistance develops. So based on the mechanism of action, we can classify antimicrobial agents into three big categories. There are agents that do block cell envelope. When I say cell envelope, I am referring to the cell membrane as well as the cell wall. Bacteria, unlike the eukaryotic cells, including us, they have cell wall. We don't have cell wall. Cell wall, plants have cell wall. Eukaryotic cells, animals do not have cell wall. So we can target cell wall synthesis. Okay? So specific targets which bacteria do have and which we do not have, thus can be targeted in when we are trying to treat. So the agents that target cell envelope, this, when I say again, I will repeat, cell membrane as well as cell wall, are beta-lactam group of antibiotics, glycopeptides, which includes vancomycin, and also you can also group daptomycin here and colistin. So these are active against cell wall synthesis. Hence, they are bactericidal. If the bacteria can't synthesize cell wall, it dies. It dies of osmosis. It will be osmotically fragile, so the bacteria dies. And also, we can target the protein synthesis in the ribosomes. Okay, so that's very unique. Bacteria are prokaryotes. And the prokaryotic cells protein synthesis is very different to that of eukaryotic cells, human cells. So here they have two subunits, the 30 and 50S subunits of ribosomes. So we can target. So the drugs that act against protein synthesis, some of them are bactericidal and others are bacteriostatic. The class includes rifamycin, aminoglycosides, macrolides, tetracyclines, chloramphenicol, clinidines, and the like. And the third is we can target the DNA, the genetic synthesis, the DNA and the replication as a nucleus. Okay, so but as you know, bacteria do not have distinct organelles because they are prokaryotic cells. And they have the genetic material floating in the cytoplasm that reproduces, and the way that it reproduces is very different from the eukaryotic cells. We can target DNA synthesis, meaning the replication cycle. So antimicrobial therapy can target at three sites. One, at cell envelope, meaning cell wall and cell membrane. The other is protein synthesis at the ribosomes. And the third is in the DNA synthesis. I mean the nucleic, the genetic against, the DNA. We can target the DNA and the replication process. Okay, so this includes very important drugs like trimethoprim sulfa, quinolines, metronidazole, and antimicrobial, antimicrobacterial agents. This you have to know. Why? Because if you want to combine, for instance, I mean, if you use two drugs that are active against cell wall, I think that is not really acceptable. So if you want to target, so the target bacteria at different size, you can combine agents that are active against the cell wall and, you know, and the protein synthesis. This is a very basic concept which I would like all of you to understand. Sorry. So again here, this diagram, you could see antimicrobial agents active against cell wall synthesis, and nucleic acid synthesis, and protein synthesis. So in my discussion today, I'm going to focus on agents that are active against cell wall synthesis. This includes the beta-lactams. The beta-lactams all have the beta-lactam ring. The most important group of class of drugs in this group are penicillins, cephalosporins, carbapenems, and monobactam. Also, the glycopeptides like vancomycin can target cell wall synthesis. Bacitracin, we don't use it for treatment in the lab. Fosfomycin, we use it very often. And cell membrane could be targeted with polymyxins and daptomycin. This is very important. Okay, you have to know this. These are very basic things. Okay, do you hear me?
Yes, we can hear you, Doctor.
Have any question? Any question? Okay. So beta-lactam, I said these are the most important group. The most important. Why? Because these are fast acting, active against all species, aerobic, anaerobic, gram-positive, gram-negative, except those agents which do not have cell wall. The lactam group of antibiotics are very active. So these are very important class. So there are 4 in this class: penicillins, cephalosporins, carbapenems, and monobactam. What they all share is they all have beta-lactam ring. That's a common feature. And another thing is they all share allergic phenomenon. If you are allergic to penicillin, it's possible that you can be allergic to cephalosporins, carbapenems, and monobactams too. Less likely is monobactam. So the features that are commonly shared by this class of drugs are they all have beta-lactam ring 1, 2, they all share this feature of being allergic. That's a commonality. And the third is tendency to cause seizure. So these 3 features are shared, by this class. All can cause seizure. Okay? If you say, for instance, imipenem causes more seizure episodes than meropenem, but penicillins in general, cephalosporins, including the rest, they can all cause seizure. So 3 features, again, I would like to underline this, shared by this class of antimicrobial agents are the ring, the beta-lactam ring. There is an adjacent ring, also you see a okay, and except for the monobactams, okay, and the tendency to cause seizure and allergy are shared. So in order for us to understand how this class of drugs act, we need to understand about the bacterial structure. Gram positives have thick cell wall, and then the cell membrane and the space between the cell wall and the cell membrane is very narrow. So actually, we say they don't have periplasm. So the part of the cell intracellularly other than organelles, it is called cytoplasm. And the part of the cell between the outer layer, the gram negatives have a thin lipopolysaccharide layer, and they have a moderately thick cell wall. They have a cell membrane. So this space is called the periplasm. So gram positives do not have periplasm. So the beta-lactams, I say, target cell wall synthesis. Cell wall synthesis, cell wall is made up of what's called peptidoglycan. These are polymers of glucose and amino acids, carbohydrate and amino acids. So they are made of an acetylmuramic acid and an acetylglucamic acid. These are, and what you have is chains of amino acids. And what this penicillin binding protein does is it is transpeptidase. It forms a glycine bridge. Like for instance, if you have a chain, unless one chain overlaps over the other, then the integrity, the strength of the chain is really affected. It's weak. It makes the chain, it locks, the glycine bridge. If an acetylmuramic acid and an acetylglucamic acid are aligned, one next to the other, then it's very structural, it's very weak. So what the penicillin binding protein does is the transpeptidase is an enzyme. It locks, forms a glycine bridge. So as you could see it here, it's like a chain armor. So it's just overlapped. So what the bacteria needs cell wall for is integrity. The cell wall is affected, then the bacteria will be osmotically labile, fragile, then it dies, it disintegrates. What you see here is a penicillin binding protein is an enzyme, and this is targeted by the beta-lactam group of antibiotics. So there is a family call. Would you please wait for me for 5 minutes? ይቅርታ አንድ 2-3 ደቂቃ ታገሱኛላችሁ?
እሺ ዶክተር።
እሺ ይቅርታ ቤተሰብ ነው። Sorry, I'm back. Can you hear me? Hello? Hello?
We can hear you, doctor. We can hear you.
Okay, thanks. Sorry for the inconveniences. So I'm going to discuss the common features among this class of drugs. They are bactericidal lysate because they target the cell wall. Once the cell wall synthesis is literally stopped, bacteria dies. And another very important feature is the pharmacokinetics. These are very basic things which we are going to address in the coming lectures. It operates in this principle: time above MIC, the time above the minimum inhibitory concentration that correlates with the efficacy. Some are like concentration dependent, like aminoglycosides. The beta-lactams is the time. That's why now we really emphasize on extended infusion or continuous infusion as a means to improve the efficacy and to reduce the rate of resistance. And another thing that you need to remember is this class of drugs, they don't have post-antibiotic effect. Like for instance, if you take aminoglycosides, administer and then stop, you might not find the drug circulating, but still you see the serum inhibiting bacterial growth. So that's what we mean post-antibiotic effect. So the beta-lactam group of antibiotics, they do not have post-antibiotic effect. What does that mean? It works when it is in our system. Okay? If there is no drug, then there is no action. And another feature which we all like is this class of drugs, they really interact with other class of drugs. So there is minimum drug interaction. So this is very, very important, okay? And another thing is, excretion here is renal, all beta-lactams, except for ceftriaxone, which is highly protein bound and is excreted by the hepatobiliary means. So these are very common features shared by agents in this class of drugs. And the resistance mechanism can be, mnemonics really assist the learning teaching process. And the 6 P's, penetration, particularly gram negatives, porins, gram negatives, pumps, again gram negative, penicillinases, penicillin bind, gram positives, and some bacteria, as I have already said, like chlamydia, mycoplasma, and so on, they do not have cell wall. So absent peptidoglycan. So these are common features which are shared by all, I would say all agents in this class. And you see what this beta-lactam ring has an affinity to the penicillin binding protein, to the complex. Okay? So this complex, this is like antigen antibody, it's kind of affinity towards the penicillin binding protein. Then it makes this enzyme, renders it inactive, so it inhibits the cell wall synthesis, then the bacteria dies. What happens when the bacteria develops resistance is it changes the penicillin binding protein. Like that's what Staph aureus does. That's what Strep pneumoniae does. So that's how these bacteria overcome this class of drugs, okay, by changing their penicillin binding protein. The penicillins, okay, now What I'm going to do is we are going to approach from the clinical pharmacologic point of view, and then we'll take some bacteria, very important bacteria, difficult to treat bacteria, and then try to discuss which of these agents are really active. So the category, the penicillins, are broad spectrum. We have the natural penicillins, penicillin G, oral penicillin. I don't think we need oral penicillin. Anti-Staphylococcus, these are semisynthetic penicillin, which can resist penicillinase. So these are methicillin, oxacillin, and nafcillin. We don't use methicillin to treat. This is just in the lab. We have nafcillin, oxacillin, and the oral agent is dicloxacillin. These are semisynthetic penicillins, penicillinase resistant penicillins. Particularly, we use them to treat skin and soft tissue infections. Then, by adding an amino group to penicillins, we extend their spectrum of action to gram-negatives. So what ampicillin is, penicillin, some action against gram-negative organisms, not the bad ones, like E. coli, which could cause urinary tract infection. Okay, for some, that result in common community-acquired infections. Adding amino group to penicillins extend the spectrum of action of this class of agents to gram-negatives. So ampicillin is an oral agent. So we have also an IV intraparenteral agent. We have the only oral agent is amoxicillin. So what the bacteria does is, in order to overcome, the bacteria produces an enzyme. We call it a beta-lactamase. So the penicillins, as well as semisynthetic penicillin, the amino, the group to which an amino group is added, are susceptible to this enzyme. What this enzyme does is it breaks ring, and thus it renders the bacteria, the drug susceptible, and the bacteria resistant to the drug's action. So we add beta-lactamase inhibitors. So like sulbactam, clavulanic acid, okay, to extended spectrum penicillins. These are, when we make this class of agents, their action against even the bad gram-negative organisms, like piperacillin, because it is susceptible. Nowadays, we don't use piperacillin alone. We use piperacillin, tazobactam, carcillin with clavulanate. So we have these drugs, coupled with a beta-lactamase inhibitors, because they are susceptible to the action of beta-lactamase, which bacteria do produce. So in other words, bacteria develop resistance particularly, and I'm referring to gram-positives. They change their target, that is a penicillin binding protein, and the gram-negatives primarily produce an enzyme, which we call a beta-lactamase, okay? So if you see the action of natural penicillins, they are active against a wide range of gram-positive bacteria, gram-negatives. When you see them having action against anaerobes, and including spirochetes. So natural penicillins have very wide spectrum of action. And this is what one of the limiting factors or concepts or issues, challenge in using this class of agents, penicillin allergy. So only agent, like for instance, your patient is critically ill, you want to use carbapenem. Suppose that patient tells you, I am allergic to penicillin, cephalosporins. Oh, get scared. What am I going to use instead? because the choice are very limited when penicillin allergy occurs. One feature is it's shared. Okay, like for instance, less than 5%, of patients with could I mean, if someone says he's truly penicillin allergic, true penicillin allergies is only 10%. 10%. The rest aren't true. So like 5% could be of patients could have also allergy to cephalosporins, and 2% to surgery cephalosporin, and 1% to carbapenems or azithromycin. So less, less allergy is seen with azithromycin. So the drug that is preferred with penicillin allergy in treating critically ill patients is azithromycin. It's a monobactam. So the allergic phenomenon is a hypersensitivity reaction. So it ranges from mild rash, it could be urticaria, to like anaphylactic shock, or even to toxic epidermal necrolysis. So very challenging. So, after we started using the natural penicillins, the bacteria, particularly Staph aureus, developed penicillinase, a kind of beta-lactamase, but active against penicillins. Then people came up with the semisynthetic penicillins, which are resistant to the action of penicillinase. Okay, so these drugs are methicillin, ampicillin, oxacillin, dicloxacillin. And what is interesting among these drugs, if you want to remember MON, methicillin, MON, oxacillin, and ampicillin. Okay, ampicillin and cloxacillin are oxacillin is an IV, dicloxacillin is an oral form. It's easy to remember, MON. Okay, so what is very interesting is these are drugs which are highly protein bound. So in clinical pharmacology, you have to know that portion of the drug that is active is a free fall. The drug is highly protein bound, and there is less free fall. Okay, that's very difficult. Okay, so it has to be moderately bound. That's how it's transported, or it has to be easily released from the bound protein. So the bound drug is not active. It has to be the free form. So like for instance, if you take ceftriaxone, is highly protein bound, and ertapenem from cephalosporins, and cefotetan is a secondary cephalosporin. These are highly protein bound. And what it means is, the importance of this is we can use huge doses, large mega doses. And these drugs are not excreted by the renal means. So no need to adjust doses when you have renal problem. Okay. As I have already said, beta-lactams are excreted through the kidneys. So they have to, renal dose adjustment should be made when the kidney function is impaired, except for ceftriaxone. Ceftriaxone is excreted through the hepatobiliary means. So mechanism, then the bacteria is intelligent enough. So what it does is it changes its penicillin binding to penicillin binding protein to A through make a gene. It changes its gene. That's how this methicillin resistant Staph aureus has developed. Your option is now vancomycin, very limited. You cannot use these drugs. For methicillin resistant Staph aureus, you can use only vancomycin, daptomycin, linezolid, and the like. So this is how the bacteria has evolved. So the penicillin-resistant semisynthetic penicillins, as I have said, we can use a high dose, and we nowadays use them to treat skin and soft tissue infections. And beyond that, their action against methicillin-susceptible Staph aureus is inferior. If you are not sure, then it's better to, if it is due to a methicillin-susceptible Staph aureus, if you use these agents, then patients really would fail to improve, and some, in fact, would face really very serious illness. So if you can't, then, if you are in a dilemma, then that's what I say always. If you are not sure you are dealing with methicillin susceptible, methicillin resistant, then combine, like triaxone with vancomycin, if you aren't really sure. The other thing is, allergy, these drugs also can cause interstitial nephritis. Okay, this is, all antimicrobial agents, if the renal toxicity is interstitial nephritis, except the aminoglycosides, which can cause tubular injury. So additional unique toxicity of penicillin can cause hypersensitivity hepatitis and so on. Okay, so the aminopenicillins. So when the amino group is added, you see now the gram-negative spectrum is broadened to include some Enterobacteriaceae like E. coli, Proteus mirabilis. Okay, so the spectrum of action is expanded. So these are very good drugs to treat uncomplicated urinary tract infections. But the problem is they are susceptible to beta-lactamase enzyme. So we couple them with a beta-lactamase inhibitor. Like here we have amoxicillin clavulanic acid, ampicillin sulbactam. These make them really potent and resistant to the action of beta-lactamase. So these are the very important group of agents, the extended spectrum penicillins. This includes piperacillin, carcillin. These are very nice group, very, very wonderful class of drugs. They have action against all except extended, Staph aureus and methicillin-resistant Staph aureus, and in pathogens which are extended spectrum beta-lactamase. These aren't preferred because in seriously sick patients. Other than that, Penicillin tazobactam, the wonderful drug. So I always say, if you have a critically ill patient, if you have to use piperacillin tazobactam, because piperacillin tazobactam has an action against gram-positive, very good action. It covers strep, except methicillin-resistant Staph aureus. Gram-negative action is broad. It has also an anaerobic action. Okay, and it's a very, very wonderful class. So because it is susceptible, we don't use it alone. We have complex piperacillin with tazobactam, the carcillin with clavulanate, and this is for overcome the beta-lactamase, that's gram-negative bacteria in particular produced. So piperacillin tazobactam is very, there are some drugs which I always say my favorites. One of which is piperacillin tazobactam. From antivirals, I like acyclovir. These are really wonderful drugs. From fungal, I like fluconazole. You can use them, they are minimal toxicity, and you can use them even at high dose range, very active drugs still. Okay, so despite all the hurdles that they do face, these drugs are still active. So one of my favorite drug is piperacillin tazobactam. It's active against aerobic and anaerobic gram-negative bacteria. So the only group of bacteria to which this drug is not active, the methicillin-resistant Staph aureus. So the dosage, it's classified as if you want to treat Pseudomonas, and if not Pseudomonas, I always say very difficult to rule out Pseudomonas. So what I always say is use, if you have to use, this is a drug which is available in our country, use 4.5 gram IV Q6 hourly. So the problem is when you combine it with vancomycin, there is a risk for an increased risk for acute kidney injury. Pearls about piperacillin tazobactam is it has lots of sodium. So particularly in patients with congestive heart failure, condition could be aggravated. And interestingly enough, I would say interestingly enough, it causes platelet dysfunction, maybe increased risk of bleeding, prolonged bleeding time, PTT. So in patients who have very low platelet counts, vulnerable for bleeding, please be careful. It could be used, but with caution. And also you have to be very cautious when you use it with renal insufficiency, particularly with vancomycin. Okay. So now, do you hear me? Are you with me, or am I alone?
Yes, we are hearing, doctor. Yes, we are
Fine.
hearing.
Fine. How many people are asleep? I can't count. Less than 50% or more than 50%? If less than 50%, I will be encouraged. The proportion of my listeners who are sleeping, is it above 50% or below 50%?
It's below 50%, definitely.
Thank you, my boy. Now I will continue. Thank you very much for encouraging me. Fine. So here you would see that's number one. What's shared by this class of drugs, a beta-lactam ring, I said. So the adjacent ring is here you have a hydrothiazine ring. Penicillins have thiazolidine ring. Okay. So what makes, these are attachments, R1 increases the attachments explain their spectrum of action. So some, like for instance, if you take a first generation cephalosporins, they are primarily gram-positive active. You go to third generation, their spectrum of action against gram-negatives is broad. So the spectrum of action is defined by R1, and R2 defines the PK properties, the pharmacokinetics properties. These are very important concepts to understand. So the cephalosporins, the first generation cephalosporins, cefazolin, we have cefazolin as a very nice drug. We say very good to use for prophylaxis. It's mainly active against gram-positives, methicillin susceptible Staph aureus, some E. coli, some Klebsiella. So no activity against enterococci. So very good drug, cefazolin. But you can't use cefazolin if you have MSSA causing infective endocarditis. Its bioavailability is time to action is really fast. It's a very nice drug. We have cefazolin. From second generation cephalosporin, cefoxitin, cefotetan. So these are active, the only ones which are active against anaerobes. So cephalosporins do not have action against anaerobes except for the second generation cephalosporins, cefoxitin and cefotetan, which are active against Bacteroides fragilis. Okay, so we have the third generation cephalosporins, which you are all familiar with, and ceftriaxone. Ceftazidime is also a third generation cephalosporin. We have a fourth generation cephalosporin, cefepime. Cefepime is really wonderful because it has a very nice, very good gram-positive action, and the gram-negative action extends to Pseudomonas. So very important drugs for you to learn, particularly in taking care of critically ill patients, are cefepime, Penicillin tazobactam, and the carbapenem. Ceftazidime is active against Pseudomonas. However, nowadays in the Kurambasa, from our studies, I don't think, ceftazidime is active because 70% of the strains in the Kurambasa, gram-negative strains. Now, Klebsiella, which is dominating the picture, is resistant to ceftazidime. So we have the 5th generation cephalosporin, ceftaroline. What ceftaroline means is, let me tell you, this is ceftriaxone plus vancomycin. That's how, if you want to understand the action of ceftaroline, ceftaroline means ceftriaxone plus vancomycin. Imagine combining ceftriaxone and vancomycin, that's what it is. So because of the emergence, the spread, the widespread of extended spectrum beta-lactamase strains of bacteria, these are gram-negatives. You're only can only treat them with carbapenems. Carbapenems are the last resort. So in the Kurambasa, the gram-negative strains, 70% of them have become extended spectrum beta-lactamase producers. So if you acquire an infection in the Kurambasa with a gram-negative bacteria, Klebsiella pneumoniae, okay, or E. coli, or Pseudomonas, we can only treat you with carbapenem. Even now, we are facing a surge of carbapenem-resistant Enterobacteriaceae. So particularly in critical care units and so on, we really face a problem. So antimicrobial resistance is a huge blow. And part of the reason why we have high mortality in our intensive care units, in critical care, in our emergency rooms, is because of widespread resistance against this class of agents. Now, if you go to the emergency room in the Kurambasa, and if you ask how many of the patients there kept there had already received ceftriaxone before referral to the Kurambasa, you'll find everyone. And we know ceftriaxone is a very good gram-negative agent, but now people give it for sore throat, which is a gram-positive, it is strep, streptococci. You can use ampicillin, amoxicillin. And that's part of the reason why the resistance has spread, is because the healthcare practice here is not really regulated. One can prescribe whatever antimicrobial agent he likes. So here you would see as a generation of the cephalosporins increases, the gram-negative action increases. But if you see the gram-positive action is broad, was really good for first generation, then it narrows down. And the third generation have little gram-positive. If you want to treat a gram-positive infection, these aren't really preferred agents. Then now, the fourth generation cefepime restores gram-positive action, and the 5th generation, and like ceftaroline and so on, has a good gram-negative and gram-positive action against methicillin-resistant Staph aureus. So the advanced generation cephalosporins are as listed. We don't have them. These are very expensive. None of them are generic. So now, in areas where the resistance to carbapenem is spreading, these are agents that have come to the forefront and very expensive and can be used if available. So this is another drug which we do have. It's a monobactam. Monobactam means it doesn't have an adjacent ring. Ceftriaxone and the cephalosporins have an adjacent dihydrothioazine ring. These ones do not have ring. So just a beta-lactam ring alone. These are very important group. So Please listen to me when I say this, because I'm going to ask you during the exam. This is the only beta-lactam agent without gram-positive activity. Okay, so all beta-lactams have a very good gram-positive action. However, azithromycin monobactams, they lack this gram-positive activity, and these are gram-negative agents. So if you think of gram-negative, gram-positive, this is not a good choice. The other thing is we use it widely used when penicillin allergy is suspected or proved. So these are two conditions which you need to know. It's available here. It's a gram-negative drug. So carbapenems, I will discuss carbapenems and then I will stop. Carbapenems are our last, defense, or I would say, any army has weapons kept for bad days, the most lethal weapons. So in our fight against bacteria, these are our last weapon that we do have, carbapenems. If we lose with carbapenems, then the game is lost. Okay, imagine, I would say the Messi, or for those of you who are fans of Ronaldo, the Ronaldo of antibiotic drugs. So the carbapenems are most precious antibiotics. Why? Because they have broad spectrum. They are active against all except methicillin-resistant Staph aureus. Again, I'll repeat, active against all except methicillin-resistant Staph aureus. So that's very desirable. Active against extended spectrum beta-lactamase producers, AMC. I will discuss this. These are rapidly bactericidal. So when someone is critically ill, seriously ill, so we want agents that are rapidly bactericidal, because we have to get rid of the bacteria. These are all parenteral. So imipenem, celastatin, we have it. Meropenem, we have it. The only one which we do not have is doripenem. And we have ertapenem. That's the first generation carbapenem. So people ask me, do we need doripenem? I don't think we need. If you use these ones, and if these ones are sustainably available, I think that would suffice. Doripenem has, some say, has a more stronger action against Pseudomonas. So carbapenems, so there are some bacteria which are intrinsically resistant, inherently resistant. So like Enterococcus faecium, methicillin-resistant Staph aureus, Stenotrophomonas, and there are carbapenemase producing aerobic gram-negative bacteria. To this class, these agents are not really active. So if there is a drug that you need to add, or carbapenems, this is vancomycin. I wouldn't add any other drug. So the one that has no action against Pseudomonas is ertapenem. All are active against Pseudomonas. You have to bear in mind, Pseudomonas is the king in the ICU. In mechanically ventilated patients, people who are kept in critical care units, the king in the ward, in these wards, in the critically care wards, is Pseudomonas. And now Acinetobacter is coming also to the picture. Okay? So ertapenem is most susceptible to carbapenemases. These are beta-lactamase. So doripenem inferior to meropenem in pneumonia trials. People compare mero and imipenem. I say they are the same, except that imi causes more seizure. So the spectrum of action is really one of the most wonderful. So what I tried to do in this 1 hour lecture was I tried to give you an overview of the targets to which these antimicrobial agents act on. So some target cell envelope, cell wall, and cell membrane. Others target protein synthesis, meaning the ribosomes. The third synthesis, nucleic acid synthesis. Today we discussed agents active against cell wall synthesis. We haven't discussed agents active against cell membrane synthesis. So I will say these beta-lactamase inhibitors, and then I'll stop. Because the bacteria, Darwin is right. Because bacteria have to survive. A species has to maintain its own survival. How bacteria ensure their survival is overcome these agents, antibiotics. In fact, antibiotics are produced by bacteria to kill other bacteria. And these bacteria, in order to survive, develop enzymes like a beta-lactamase. Particularly, this is a problem with gram-negative. So we can't inhibit these enzymes. So the most important agents are clavulanic, sulbactam, tazobactam, avibactam, and vebrobactam. What this is, have a beta-lactam ring, but have no antibacterial action. So when the drug is given, coupled with these inhibitors, so the bacterial enzyme beta-lactamase binds to the beta-lactam ring of clavulanic, sulbactam, tazobactam, and the drug is left active. Like if you Penicillin, tazobactam, the beta-lactam attached to tazobactam, and the piperacillin is free to act on the gram-negative bacteria. Like a burglar comes to your house, and what it does is, if you have a killer dog, the burglars carry food that's very attractive to dogs, like meat and so on. So they give the meat. So when the dog is engaged with the meat, enjoys the meal, the burglar does its job. That's what these beta-lactamase inhibitors do. If you have questions, I will let you ask. How many survivors, Bamlak? Did you count the
We have
survivors?
7 participants. Still,
Any
it's more
question?
than 50%.
Survivors.
We have 37 participants right now, and those who are awake, I'm sure there are more than 50%.
Oh, really? That's wonderful.
Yes.
Never in the
Yeah.
history. It's going to be a recur. Any
Yeah.
question?
Can I ask a question, doctor?
Please.
Okay. Recently, like a combination of ceftriaxone and cephalosporins is being available in the market, and I've seen it being used especially for COVID patients. So regarding that, how can we incorporate in our care, like as a step up or step down in our antibiotic use? For example, if a patient is on ceftriaxone, if he's not improving, will he benefit in a step up to ceftriaxone cephalosporin combination, or should we go ahead and increase it to the 4th generation cephalosporins?
Yeah, a very nice question. Actually, at the end, I will give you a talk on super infection, co-infection with COVID-19. Actually, this is a very wonderful drug. Let me tell you, the world is biased. Why I say? Because, ceftriaxone, sulbactam, there is ADTA. ADTA makes it even more important because, it acts against this serine metallobeta-lactamase. Okay, and because this is produced by India, okay, the whole concept is from an Indian scientist, clinical pharmacologist, and it is, you see, it's less is talking about this drug. I found it really very useful. In I use it to spare carbapenems. We have to spare carbapenems. One of the strategies which I really adopt is using this drug, ceftriaxone, sulbactam with ADTA, Pipezo, Efipim. These are what I use as forefront. So when I fail, I use carbapenems. Okay. So I'll give you some talk on this when time allows, or maybe after the series of lectures are gone. But this is really wonderful. This is what I would say. The recovery trial now, you see, from the UK, which proved Dexamethasone really decreases mortality with severely sick COVID patients. The Chinese had already, before the recovery trial, a Chinese paper published, a study published in Lancet showed it really works. Nobody accepted them. So if a study comes from Europe or the United States, before people, read the whole paper and examine the facts, it's very likely it's going to be accepted. If a study, a new thing comes from Africa, then people really hesitate. So it will take you years to convince them. So good example is Endode. Endode is just found very active against schistosoma, the snails, and environmental friendly. But Professor Akilulema spent his entire life trying to convince the pharma, and he failed to do so. So that's, and for me, it's a very wonderful drug. I use it, and the dose I suggest is in a patient who is not critically ill, use 1.5 gram BD. Critically ill patient use 3.5 grams, 3 grams BD. Ceftriaxone, sulbactam with ADTA. The spectrum of action is really, it's very wide. So this is what I say about this drug. It's going to restore the grace of ceftriaxone. Ceftriaxone lost its grace because of resistance. Now I think this drug is going to restore it. That's how it's. Any other question? Fine. If there are no other questions, then have a nice day and are willing to share the slides. There is one in the chat box, sorry, let me see it. Is there any benefit of adding another anti-pseudomonal? No. This is a very good question, Nati. I'd like to thank you for raising this. I see these days people adding fluoroquinoline, ciprofloxacin to meropenem. That's crazy. Please don't do it. Meropenem doesn't need. If there is anything that mero does is maybe add vancomycin. So it can't cover against the medicine resistant stuff. So you do more bad than good. You do worse than good if you add ciprofloxacin to meropenem. Please don't do it. Are you there, Nati?
Yes, doctor.
Let's go. Okay, fine. Nice to hear.
Can I add on his question? How about in ventilator-associated pneumonia? In those situations, to say that it's better to add dual anti-pseudomonas with a MRSA coverage.
No, that's absolutely wrong. I'm going to discuss that. Absolutely wrong. Absolutely wrong.
Okay.
Fine. Have a nice day.
Okay. Thank you, doctor.